Your heart can beat more than 100,000 times in a day, and most of the time you never notice it. Then suddenly it may feel as if something has changed. A flutter in the chest. A pounding pulse. A strange irregular rhythm that seems to skip, race, and stumble all at once. Or there may be no sensation at all. One possible reason is atrial fibrillation, often shortened to AFib or AF. It is a common abnormal heart rhythm, but common does not mean simple. Some people have brief episodes and feel every one of them. Others live with AFib for a long time without obvious symptoms. And the most important issue is not always how fast the heart feels. AFib can also increase the risk of blood clots and stroke. That sounds alarming, but there is an important counterpoint. Atrial fibrillation is something modern medicine understands well, and there are several ways to reduce its risks and control its symptoms. The key is recognizing what AFib is, what it is not, and why treatment is different from one person to another. To understand AFib, picture the heart as a 4-room pump with its own electrical wiring. The 2 upper chambers are called the atria. The 2 lower chambers are the ventricles. Normally, an electrical signal begins in a small group of cells called the sinus node. This signal spreads across the atria in an organized way, then travels through a natural electrical gateway to the ventricles. The result is a coordinated beat, upper chambers first, lower chambers next. In atrial fibrillation, that organized pattern breaks down. Instead of one clear electrical signal moving smoothly across the atria, many disorganized signals compete with one another. The atria no longer squeeze in the usual coordinated way. They quiver or fibrillate. The electrical gateway between the atria and ventricles, called the AV node, blocks many of those chaotic signals from reaching the lower chambers. But some still get through, often at irregular intervals. That is why the pulse in AFib is typically irregular and may also be fast. This does not mean the heart has stopped. It is still pumping blood. But the pumping system is less coordinated, and in some people that reduces how efficiently the heart works. If the ventricular rate stays very fast for long periods, the heart can become strained. And because the atria are not contracting normally, blood can move more slowly in parts of the upper chambers. One area is especially important, a small pouch connected to the left atrium called the left atrial appendage. In AFib, blood can stagnate there and, in some people, form a clot. If a clot leaves the heart and travels to an artery supplying the brain, it can cause an ischemic stroke. This is why stroke prevention is such a major part of AFib care. But not everyone with atrial fibrillation has the same stroke risk. Age, high blood pressure, diabetes, heart failure, previous stroke, vascular disease, and other factors can change the risk considerably. Clinicians use validated risk assessment tools together with the person's medical history to decide whether medication to reduce clot formation is appropriate. What does atrial fibrillation actually feel like? The classic symptom is palpitations, an unusual awareness of the heartbeat. People may describe a fluttering feeling, a pounding heartbeat, a rapid pulse, skipped beats, or a rhythm that simply feels chaotic. Some notice it when lying quietly in bed. Others feel it while walking upstairs or exercising. But palpitations are only one possibility. AFib can cause shortness of breath, reduced exercise tolerance, dizziness, lightheadedness, weakness, chest discomfort, or unusual fatigue. A person who used to walk several blocks comfortably may notice that the same distance suddenly feels harder. Someone else may feel unusually tired for days without realizing the heart rhythm is involved. The less obvious part is that atrial fibrillation may cause no noticeable symptoms at all. It can be discovered during a routine pulse check, an electrocardiogram done for another reason, or an alert from a wearable device. That does not make symptom-free AFib automatically harmless. It simply means symptoms are not a reliable way to measure risk. It is also important not to assume that every flutter or racing heartbeat is atrial fibrillation. Anxiety, caffeine, fever, dehydration, anemia, thyroid disease, other heart rhythm disorders, and many other conditions can produce similar sensations. A symptom can point toward a problem, but it cannot identify the diagnosis by itself. AFib can appear in different patterns. In some people, episodes start and stop on their own. This is often called paroxysmal atrial fibrillation. An episode may last minutes, hours, or longer. In others, AFib continues and may need treatment to restore a normal rhythm. Over time, the pattern can change. Intermittent AFib can become more persistent. Why does atrial fibrillation develop in the first place? There is rarely one single explanation. Think of AFib as the result of a vulnerable electrical system meeting the right triggers and stresses. Aging can change the structure and electrical properties of the atria. High blood pressure can make the heart work against greater resistance and can contribute to enlargement and remodeling of the atria. Heart valve disease, coronary artery disease, heart failure, and some forms of cardiomyopathy can also create conditions in which AFib becomes more likely. Other medical conditions matter too. An overactive thyroid can accelerate the heart and contribute to abnormal rhythms. Sleep apnea, in which breathing repeatedly stops or becomes shallow during sleep, is strongly associated with atrial fibrillation. Diabetes, chronic kidney disease, obesity, and some lung diseases are also linked with higher risk. Alcohol can be another factor. Heavy drinking and binge drinking can trigger AFib in some people, and even among people who already have AFib, reducing alcohol may decrease episodes. Smoking is also associated with cardiovascular harm, and is another reason tobacco cessation is part of overall risk reduction. Very intense endurance exercise over many years has been associated with AFib in some athletes, while regular moderate physical activity is generally beneficial for cardiovascular health. That distinction matters. The message is not that exercise is dangerous. For most people, appropriately chosen exercise is part of keeping the heart healthy. AFib can also appear temporarily during acute illness or after surgery. Severe infection, inflammation, major physiological stress, or changes in fluid and electrolyte balance can contribute. Even when AFib first appears during an acute illness, follow-up may still be important because the rhythm can recur later. Sometimes, after a careful evaluation, no single cause is found. Medicine does not always provide a neat answer to the question, "Why did this happen to me?" What matters is identifying the factors that can be treated or modified and assessing the risks that come with the rhythm itself. So how is atrial fibrillation diagnosed? The central test is an electrocardiogram, usually called an ECG or ECG. Small electrodes placed on the skin record the heart's electrical activity. AFib creates a characteristic pattern. The normal organized atrial activity is absent and the ventricular rhythm is irregular. The challenge is that intermittent AFib may not be happening during a short office ECG. If symptoms come and go, a clinician may recommend longer monitoring. That could mean a Holter monitor worn for a day or two, a patch monitor worn for days or weeks, an event monitor activated when symptoms occur, or in selected cases a longer-term implanted monitor. Consumer smartwatches and other wearables have made rhythm information much more accessible. Some devices can detect an irregular pulse or record a single lead ECG. These tools can be useful clues, especially when an episode is intermittent. But an alert from a device is not the same as a complete medical diagnosis. False alarms happen, and other rhythms can look similar. A clinician may need to review the tracing or obtain a medical-grade ECG. Once AFib is confirmed, the next question is not simply how do we stop it. The evaluation usually looks for the bigger picture. Blood tests may check thyroid function, blood count, kidney function, electrolytes, and other issues depending on the situation. An echocardiogram, which is an ultrasound of the heart, can show heart size, pumping function, and valve problems. Clinicians may also ask about sleep, alcohol, blood pressure, exercise, medications, and other medical conditions. Treatment then has several goals, and the priorities can be different for different people. One goal is preventing stroke and other blood clot complications. If a person's estimated stroke risk is high enough, a clinician may recommend an anticoagulant. These medicines reduce the blood's ability to form harmful clots. They can substantially lower stroke risk in appropriately selected patients, but they also increase bleeding risk. That is why the decision is individualized. For many people who need anticoagulation, modern direct oral anticoagulants are preferred over warfarin, although there are important exceptions, including certain types of heart valve disease or mechanical heart valves. The exact choice depends on medical history, kidney function, other medications, bleeding risk, cost and access, and other clinical factors. Anticoagulants are not medicines to start, stop, skip, or adjust casually. If you already take one, changes should be discussed with the clinician managing your care. The same applies before surgery, dental procedures, or when another doctor suggests a new medicine that could interact with it. Another goal is controlling how fast the ventricles beat. This is called rate control. Medications such as beta blockers or certain calcium channel blockers may be used in appropriate patients, and other options are sometimes considered. The choice depends on factors such as blood pressure, heart function, symptoms, and other conditions. A different strategy is rhythm control, trying to restore and maintain the heart's normal rhythm, known as sinus rhythm. This can involve antiarrhythmic medications, electrical cardioversion, catheter ablation, or a combination of approaches. Electrical cardioversion is a planned procedure in which a controlled electrical shock is delivered to the heart under sedation to reset the rhythm. It is not the same as the dramatic emergency defibrillation scenes often shown on television. Cardioversion can be highly effective at restoring normal rhythm, but AFib may return later because the underlying tendency remains. Timing matters because if AFib has been present long enough, a clot may have formed in the atrium. Depending on the situation, clinicians may use anticoagulation before and after cardioversion or perform imaging to look for a clot. This is one reason people should not try to manage prolonged episodes on their own based on a previous experience. Catheter ablation is another important treatment. During an ablation procedure, thin catheters are guided into the heart through blood vessels. The goal is to isolate or modify areas that are generating or sustaining abnormal electrical signals, often around the pulmonary veins where many AFib triggers begin. Ablation is not a guaranteed cure. Some people need more than one procedure and AFib can recur. But for selected patients, especially those with symptoms, ablation can reduce the burden of AFib and improve quality of life. Modern guidelines also support earlier rhythm control strategies in appropriate patients rather than automatically waiting until symptoms become severe or years have passed. There is no universal best treatment for every person with atrial fibrillation. One person may feel well with good rate control and appropriate stroke prevention. Another may have disabling symptoms despite a reasonable heart rate and benefit from a rhythm control approach. Someone with heart failure may have a different set of priorities. The plan should match the person, not just the egg. That makes the conversation with a clinician especially important. Useful questions include: what is my estimated stroke risk? Do I need an anticoagulant and why? What are my bleeding risks? Is my heart rate adequately controlled? Would rhythm control make sense for me? Is there evidence of heart failure or valve disease? Should I be evaluated for sleep apnea? Could alcohol, high blood pressure, thyroid disease, or another condition be contributing? If I have another episode, when should I call the clinic and when should I go to emergency care? Lifestyle is not a substitute for medical treatment, but it is now considered a real part of atrial fibrillation management. Blood pressure control matters. High blood pressure can place chronic stress on the atria and is one of the most important modifiable cardiovascular risk factors. If you have hypertension, taking prescribed treatment consistently and checking whether your blood pressure is actually controlled can be just as important as discussing the rhythm itself. Weight can matter as well. For people with overweight or obesity, gradual, sustainable weight reduction may reduce AFib burden and improve cardiovascular health. This does not require a crash diet, a detox, or a supplement. In fact, extreme or unproven approaches can create new problems. The evidence supports long-term risk factor management, not quick fixes. Regular physical activity is generally encouraged, with the amount and intensity tailored to the person's health, symptoms, and medical advice. Exercise can improve fitness, blood pressure, weight, and overall cardiovascular health. If exertion causes chest pain, fainting, severe breathlessness, or a sudden dramatic change in symptoms, that is not a signal to push harder. Sleep deserves attention too. Loud snoring, witnessed pauses in breathing, waking up gasping, morning headaches, or major daytime sleepiness may be clues to sleep apnea, although they do not prove it. If those symptoms are present, discussing sleep evaluation with a clinician can be worthwhile. Alcohol is another practical topic. If AFib episodes seem to follow drinking, that pattern is worth taking seriously. For people with AFib, reducing or avoiding alcohol may help reduce episodes, particularly when alcohol has been a trigger. There is no need to turn this into a moral judgment. It is simply one of the modifiable factors that can affect the heart's electrical stability. Caffeine is more nuanced. Many people assume coffee automatically causes atrial fibrillation, but moderate caffeine intake does not appear to trigger AFib in everyone. Individual responses vary. If a specific drink repeatedly seems to provoke palpitations, it is reasonable to discuss that pattern and consider reducing it, but a universal ban on coffee is not supported for every person with AFib. What about complications? Stroke is the complication that receives the most attention, and for good reason. But atrial fibrillation can affect the body in other ways. If the heart rate remains too fast for too long, the heart muscle can weaken, a problem sometimes called tachycardia-induced cardiomyopathy. AFib can also worsen existing heart failure, reduce exercise capacity, interfere with sleep, and affect quality of life. There is also growing evidence connecting AFib with cognitive decline and dementia, although the relationship is complex and can involve shared risk factors, strokes that are clinically obvious, and possibly smaller vascular injuries. This does not mean that someone with AFib will develop dementia. It means good cardiovascular and stroke prevention remains important over the long term. When should someone seek medical attention? A new irregular heartbeat, repeated unexplained palpitations, new shortness of breath, unusual exercise intolerance, dizziness, or fainting deserves medical evaluation. The timing depends on severity and context. A brief mild episode in someone who feels otherwise well is different from a rapid irregular heartbeat accompanied by chest pressure and severe breathlessness. If you already have diagnosed atrial fibrillation, your care team may give you a specific plan for what to do when symptoms return. Follow that individualized plan rather than assuming every episode should be handled the same way. Some symptoms require urgent or emergency action. Call emergency medical services immediately in your country if there are signs of a stroke, sudden weakness or numbness of the face, arm, or leg, especially on one side. Sudden difficulty speaking or understanding speech, sudden loss or major change of vision, sudden severe loss of balance or coordination, or a sudden severe neurological change. Do not drive yourself if you may be having a stroke. Stroke treatment is extremely time-sensitive. Emergency care is also appropriate for severe or persistent chest pain or pressure, severe shortness of breath. Fainting or near fainting with ongoing symptoms, collapse, or a rapid or irregular heartbeat accompanied by signs that you are seriously unwell. Chest pain can have many causes, but a heart attack cannot be ruled out by the way the pain feels or by the presence of AFib. The same principle applies in the other direction. Not every fast heartbeat is an emergency, and not every palpitation is AFib. Medical evaluation is about sorting out what is actually happening instead of guessing from symptoms alone. One of the most useful things to understand about atrial fibrillation is that the condition is not just a number on a heart rate monitor. Good care looks at 4 connected questions: what other health problems are driving the rhythm? How can stroke risk be reduced? How should the heart rate or rhythm be managed to improve symptoms and health? And how should the plan be reassessed as the person and the condition change over time? That last question matters because AFib is dynamic. Symptoms can change. Risk factors can change. Kidney function, blood pressure, weight, medications, and other conditions can change. A treatment plan that made sense several years ago may need to be reviewed. If a wearable has shown an irregular rhythm, if your pulse has suddenly become unpredictable, or if you have symptoms that concern you, the goal is not to diagnose yourself from a video. The useful next step is to bring good information to a healthcare professional. What you felt when it happened, how long it lasted, what you were doing, whether you had chest pain or fainting, and any rhythm recordings your device captured. Atrial fibrillation can be silent, intermittent, persistent, mildly annoying, or deeply disruptive. But its risks can often be assessed, its symptoms can often be improved, and the major complications can often be reduced with evidence-based care. The rhythm may be irregular. The approach to it should not be: confirm the diagnosis, understand your personal risks, treat the conditions that contribute to AFib, and make decisions about stroke prevention and rhythm management with a qualified healthcare professional. This information is for general education and is not a diagnosis or a substitute for individual medical care. If you are experiencing emergency symptoms, seek emergency medical help immediately in your country.